pacientes con fibrilación auricular y prevención del accidente cerebrovascular.
Okay, well, thank you very much for inviting me to this session, and I'm very, very pleased to talk to you today about stroke prevention in atrial fibrillation with the NOACs. These are my disclosures. So I think when we talk about the safety of NOACs, it's very important that the most important thing we can do is ensure that patients who need to be on oral anticoagulation are actually on oral anticoagulation. And this is the most recent version of the algorithm developed by the Canadian Cardiovascular Society guidelines, which tries to harmonize both the CHADS and the CHADS-VASc. And you can see here, for example, that sex is not one of the risk factors considered, and vascular disease is not considered the same as some of the other risk factors. But of course, there are some important subgroups that we always get very nervous about when we start oral anticoagulation, and I want to highlight some of the newer data that has become available recently around some of the renally impaired patients, including dialysis, patients with liver disease, and patients at the extremes of body weight, either very, very low body weight or very, very obese. So if we look at the renal impairment question, it's very important to understand the pharmacokinetics of the various NOACs. And even though we know that all of the NOACs to a certain degree are cleared by the kidneys, it's important to realize that even in very severe renal impairment, there's not a lot of difference in the concentration of the factor Xa inhibitors compared to patients with only mild renal disease. And that should be reassuring to everybody who is using NOACs in patients, because of course, if your patient has renal disease, we know that it's only going to progress over time. The exception is probably dabigatran, which is the most dependent on renal clearance, and typically I do not use dabigatran in patients with renal dysfunction. So we know that renal dysfunction is not stable. It's always getting worse. It may be getting worse very quickly, it may be getting worse slowly, but we know that it's always moving in one direction. And so people will say they feel okay using NOACs in patients whose renal dysfunction is very stable, but they get very nervous about using NOACs in patients with actively worsening renal function. And yet when you compare the outcomes of patients with actively worsening renal function, NOACs actually look comparatively better than warfarin in the patients whose renal dysfunction is going down versus patients where the renal function is stable. And this may be a bit surprising to people, but one must remember that warfarin is not a very good drug for patients with renal failure. It's more difficult to titrate to keep a stable INR, and this is another reason why warfarin may not be a very good drug in patients with worsening renal failure. Vitamin K inhibition not only inhibits clotting factors, but it also inhibits other vitamin K dependent mechanisms which prevent renal vascular calcification. And we know, for example, that calciphylaxis, which is a diffuse calcification, can happen in a small percentage of patients on dialysis who are taking warfarin. This is just a more subtle presentation of this kind of calciphylaxis. And this progressive renal vascular calcification can lead to decline in renal function over time. So this is some data from the Mayo Clinic where they compared the performance of warfarin, which is in the red line, compared to the three other principal NOACs, apixaban, dabigatran, and rivaroxaban, There wasn't enough data here to include edoxaban as well. And you can see here that when it comes to progressive decline in GFR, or in terms of doubling of serum creatinine, warfarin was associated with a much more rapid decline in renal function compared to any of the other NOACs. So again, another reason why warfarin may not be your best choice in renal dysfunction. Now, what about dialysis patients? Should we be providing warfarin for oral anticoagulation of our atrial fibrillation patients who are on dialysis? And this question is actually very controversial, because if you review all of the stroke prevention trials with warfarin in dialysis patients, what you'll notice is that the risk of stroke and death is actually increased by warfarin, not decreased. And of course, it goes without saying that the risk of bleeding is also worse. So in fact, this led the Canadian Cardiovascular Society Atrial Fibrillation Guidelines Committee to recommend that warfarin should never be used in dialysis patients with atrial fibrillation, based on all of the available data. But what about NOACs in the dialysis population? Can we safely use them? Well, as I mentioned earlier, even in patients with severe renal dysfunction, there may not be a lot of change in the concentration and anti-10A activity of the factor X inhibitors. So this is an example of rivaroxaban, and you can see that the pink curves represent healthy volunteers, whereas the gray curves represent patients who are receiving 15 milligrams of rivaroxaban on dialysis. And you can see that the concentration curves and the anti-10A activity curves are pretty much exactly the same in all of these patient populations. And when you look at the total area under the curve and the maximum concentrations, you can again see that the area under the curve for rivaroxaban is remarkably consistent across all of the stages of renal disease, including dialysis. Now, of course, apixaban was the first agent that was given approval for use in dialysis patients, and because of that, we now have a lot of data on apixaban and its use in hemodialysis patients. And you can see that compared to warfarin, there was no real difference in stroke and systemic embolism, but there was a significant reduction in major bleeding afforded by apixaban versus warfarin, which is what we would have expected. However, this data was a little bit surprising. When intracranial bleeding was compared and when total death was compared, there seemed to be no advantage of apixaban over warfarin. And we would have expected, especially for intracranial bleeding, that this is one of the key areas where there is consistency in the behavior of NOACs over warfarin, and we didn't see that in this data set. So it's far from clear that apixaban or NOACs are the right choice in the hemodialysis patient. Having said that, the FDA has given the green light now for both apixaban and rivaroxaban to be used in the hemodialysis patient population. And there is some building evidence now about the use of rivaroxaban, although it's very small compared to the amount of evidence that we had for apixaban. So if we look at this recently published study with only a very tiny number of patients, only 377 patients, we see that stroke and systemic embolism certainly looks better with rivaroxaban versus warfarin, although minor bleeding is no different, and GI bleeding may or may not be better as well. And if we look at this recent meta-analysis of dialysis patients receiving NOACs, and they tried to exclude very, very small studies, We can see here the various NOACs, and again, for edoxaban, there just hasn't been enough data out there to do the meta-analysis. But for apixaban, there seems to be no difference in terms of stroke reduction, and there also doesn't seem to be much of a difference in major bleeding. For dabigatran, there's no difference with stroke, although a higher risk of bleeding. And for rivaroxaban, we also see no difference in stroke and no difference in bleeding. Now, I want to talk very briefly about liver impairment. We always talk about renal impairment in NOACs, but what about patients with liver disease? And actually, this is some very nice data that was recently published by Greg Lip and some of his Korean co-investigators from the Korean National Health Database. They defined liver disease based on ICD-10 codes, so there is a little bit of a limitation in this. But what's very interesting is that even in patients with active liver disease, across the board, when it comes to ischemic stroke, GI bleeding, hospitalizations, and a composite outcome, the DOACs are outperforming warfarin even in patients with active liver disease. And I would encourage you to read this article. It came out very, very recently. And finally, I'm going to talk about the extremes of body weight. So we know that very, very small patients may behave differently with NOACs. And we also have a sense that the morbidly obese patient may not perhaps be receiving enough NOAC and therefore may have to be dose adjusted. So how does body weight affect the performance of the NOACs? So again, this is data that came out very recently from the same group, Greg Lip and his Korean co-investigators from the Korean National Database, and they looked at patients with a body weight of less than 60 kilos, and they even looked at patients with body weight less than 50 kilos, so very, very small patients. And again, consistently across the board, they found that for ischemic stroke reduction, GI bleeding reduction, decrease in hospitalization, and in the composite outcome, DOACs were significantly better in all categories versus warfarin. And finally, for morbid obesity, there isn't a lot of data out there about how the NOACs act in the very, very obese patients. But this is some data that has just been published online. It hasn't been formally put into press yet, which compared rivaroxaban versus warfarin in the very morbidly obese patient with a BMI of greater than 40. And what was reassuring is that when it came to stroke and systemic embolism reduction, there was absolutely no difference between the behavior of rivaroxaban and warfarin, even in the morbidly obese patient, and the risk of major bleeding was also remarkably consistent. So in conclusion, I would like to say that now that we are more than 10 years into the NOAC era, we have studied these drugs in multiple risk groups. And over again, we are seeing the consistency of both the safety and efficacy of these drugs, even in our highest risk patients with renal impairment, liver disease, and the extremes of body weight. And I think we should have very little hesitation in this day and age for using these agents appropriately for a broad spectrum of patients. Thank you very much.